for today's program. Speaking today will be Associate Professor of Law, Lance Gable, and the Dean of College of Fine, Performing and Communication Arts, Matthew Seeger. Professor Gable is an internationally known expert on public health law and bioethics. He has assisted with the development of course materials for the World Health Organization, Diploma in International Human Rights and Mental Health, and has worked as a human rights consultant for the Pan American Health Organization. Prior to joining Wayne Law, he was a senior fellow at the Centers for Law and Public Health, a collaboration between Georgetown and Johns Hopkins universities. Dean Seeger is a renowned expert on crisis and risk communication and crisis response and agency coordination. He has worked with the Centers for Disease Control and Prevention for more than a decade and is also a member of the World Health Organization Guidelines Development Group for Emergency Risk Communication. His work on crisis, risk, and communication has appeared in more than 100 journal articles, book chapters, and conference proceedings. Needless to say, we are delighted that we have two such amazing experts right here with us today. Before I hand things off to Professor Gable to begin the presentation, I'd like to go over a couple of housekeeping items for using Zoom. Please keep your mic muted and feel free to turn your video off. If you have a question, please use the chat feature. We will monitor throughout the event, and I will read the questions during the Q&A period at the end of the event. Our goal is to have each speaker present for approximately 20 minutes each, and then allow for about a 20-minute Q&A period. With that, I will let Professor Gable take it from here.
Well, thank you, Kathy, for that great introduction, and it's a real pleasure to be here with all of you today via Zoom. We hope that this session today and then the ones that we're going to have over the next few weeks can provide some insight, perspective, and good information about what's going on with this outbreak, some of the legal issues that are going to come up, and some of the really practical and pragmatic things that we can all be doing to get through this challenging time together in a way that allows us to support each other. And so I am going to share my screen here. I have some slides that go along with my talk today. And basically what I'm going to try to do in the time that I have is to cover some very general issues about how the law applies to responding to an outbreak like the COVID-19 outbreak. This is an infectious disease that emerged very recently, only a few months ago, and was identified fairly quickly in an outbreak that was going on in China, but pretty rapidly spread to the rest of the world. And now we're seeing widespread outbreaks globally. There are nearly 900,000 known infections, and I want to emphasize the word known because there are certainly far more infections than that, but they haven't been detected because testing is not as widespread as it could be to try to identify quite how broad this outbreak is at the moment. We also know that there are at least 44,000 deaths that have been attributed to this outbreak. Those numbers are changing rapidly because this outbreak is growing rapidly. And so as we think about how we should be responding and how, some of the issues that come up in thinking about how to respond, understanding the science and the epidemiology behind this outbreak, those are really important data points to keep in mind. We had a fairly slow initial response in the United States, but we've really ramped that up in the past couple of weeks, in particular with aggressive distancing measures in many states and localities to try to keep people apart and to slow the spread of the disease in order to preserve capacity in our healthcare system. One of the real challenges that we face right now with this outbreak is that because so many people are becoming infected in a short amount of time, and many of those people have serious symptoms, including symptoms that require hospitalization, and in some cases really aggressive treatment like ventilators. We've seen a great deal of concern that our healthcare system can't actually handle the capacity of all of these additional sick patients who need aggressive care. And so, so one of the things I'll be talking about a little bit later is how the law can be used to try to facilitate that reduction in spread, how we can use legal powers and some of the limitations on those powers to try to keep people from spreading the disease by staying at home, by not interacting with each other, and so on. So, but I think one point that I really want to drive home today is at the bottom of the slide here, that law does play a vital role in the outcome. You know, how we get through this. The law has an important contribution to make to that, and I'm going to talk a little bit more about that in my remarks today. So, one thing I wanted to also highlight before I got into the legal aspect of my talk is just a little bit of the science behind how we decide how to respond to infectious diseases. The things that you always want to know if you have a new infectious disease that hasn't been well studied or hasn't been in human populations before, you need to know how the disease is spread. You need to know how easily it's spread from person to person. And you also need to know the case fatality rate. So for each person that gets infected, how likely are they to die from the disease? How likely are they to get seriously ill from the disease? Some early studies that have been done on this particular disease, on the COVID-19 outbreak, show that it has an R0. R0 is the measurement of how many people each infected person infects. And so we see that the R0 is between 2 and 3. That doesn't sound like a lot. It means that each person who gets this infection tends to spread it to between 2 and 3 other people. It doesn't sound like a lot, but if you actually map it out and use data to see how that affects spread, what ends up happening is that if each person is infecting 3 others, and then those 3 are infecting 3 others, and so forth, by the time you get 10 transmissions down the line, 59,000 people have been infected by that initial infection. And so, as you can see, you know, this could be quite dangerous and could spread quite quickly. The other factor that's really important here is that this disease can be contagious before people have symptoms. And so a lot of people who don't develop symptoms until later, or who develop very mild symptoms and don't even realize they have this infection, are still able to infect other people, and some of those people will have more serious consequences. And so, at least right now, before we have the capacity to do widespread testing for this disease, there are limits to the approaches that we can use to intervene. I mentioned case fatality rates. This is still something that is a bit in flux. And it's actually something that can be affected by how we respond and what our healthcare capacity is to treat people. You know, some of the early data, this data is from about a month ago, so it's already outdated, but it showed that the COVID-19 case fatality rate was between 2 and 3%. That's substantially higher than seasonal flu, which is only 0.1%. You can see from these charts that the COVID-19 infection seems to be much more dangerous to people who are older. In part that's because older people also tend to have other pre-existing medical conditions that might make this infection more dangerous and have more serious consequences for their health. But this is something that needs to be kept in mind in thinking about how we design our intervention strategies as well. And finally, this is the last non-law slide that I have, but I wanted to put this up there for those of you that are at home and you're wondering whether or not you've been exposed to this disease, whether you're wondering whether or not you have the symptoms that could indicate that you're infected. Obviously, it's hard to know for sure because many of the symptoms that this disease creates are symptoms that also are caused by other kinds of infectious diseases. But so some early data, again, from the outbreak in China, showed that a substantial majority of people who were infected with COVID-19 developed a fever. In some cases, it was a mild fever. In some cases, it was a more severe, elevated fever. Also, a high number of people had dry cough. And then, you know, on down the list here, some people had fatigue, sputum production, shortness of breath, and then so on down this list. And so, obviously, if you have any cold symptoms, you should be extremely careful right now. You should be using good hygiene, regardless of whether you think you're infected or not, including frequent hand washing and social distancing. Okay, so I want to get on to some of the legal issues, and again, you know, to make sure that that we have time. We want to make sure that we have time for lots of questions in this session as well. When we think about how the law can be used to intervene in a pandemic, Obviously, there are many options. There are many legal powers that exist. It depends on which level of government you're talking about. There are some powers that exist within the federal government. The federal powers, for those of you that have already taken constitutional law and understand where some of those powers reside, obviously they're split amongst the different branches of government. The executive branch is going to be taking the most direct action to try to intervene. But obviously, Congress has an important role to play, especially not only in delegating certain authority to the president and other executives at the federal level, but also in changing underlying legislation that allows for allocations of resources and also changes to some existing rules that might impede responses or might need to be loosened in order to allow people to ride this out in a way that isn't too damaging to their well-being. And we can contrast that, though, with what the powers that exist at the state and local level. State powers are extremely strong when it comes to responding to public health threats. And so the state police powers, which are very broad, can be used by governors in a fairly proactive and aggressive manner to try to intervene, to respond to outbreaks like this. And we've already seen many examples of this. The state stay-at-home orders that are in place in many states around the country right now. Some of the other initiatives to try to ramp up social support for people who are, who lost their income, are at risk of being evicted or at risk of being fired. There are a lot of things that can be done that can protect people from those kinds of consequences during an outbreak. Governors have a great deal of power to try to, and also to commandeer property, to use public property or even private property to expand capacity to house patients, for example, if the hospitals don't have enough capacity within their own existing structures. And so all these things are possible. And so I guess the short version of this is that there's an extensive amount of power available to governmental officials, particularly at the state level, to try to intervene and respond to a pandemic. And so I'd like to just talk about a couple of different ways that legal powers can be used in this manner. And I'm going to talk briefly about medical countermeasures, using medical approaches to try to intervene. I'm going to spend more time talking about non-medical countermeasures. Many of these initiatives can be implemented through emergency declarations that either the president or state governors have the authority to issue. And we've seen right here in Michigan, we've seen a lot of executive orders coming from Governor Whitmer, pretty much every day or every other day, trying to respond and expand some of the efforts that the state is making to try to intervene and stop the spread of this disease and to help people. We also see legislative modifications. So a good example of this is, the rapid legislation that Congress passed last week to try to provide extra financial support for individuals and some other features as well to try to get ahead of this. Although we're not, in my opinion, we're also not acting nearly as aggressively as we need to be right now if we really want to stop the spread of this disease in a way that can save a lot of people. And then the last category here, which I'll touch upon in the next few minutes as well, is judicial challenges. Even though legal powers are quite broad in responding to public health threats, those powers are not unlimited. Individual rights do not go away during a pandemic. There still are protections in place that need to be followed and upheld. And so we're likely to see a wide range of legal challenges that can come out of the efforts that are being implemented right now. So medical countermeasures. Now, there are a number of ways that you can try to intervene to try to stop the spread of an infectious disease that involve medical countermeasures. Now, some of these medical countermeasures really aren't available yet to respond to the COVID-19 outbreak. And in part, it's because it's a new virus. Humans have not been infected with this virus before. And so the entire human population is immunologically naive. In other words, our immune systems are not ready to fight off this virus yet. Now, as more and more people are infected and then recover from this disease, there will be some level of immunity among some people in our society. what we're hoping to do as rapidly as possible, and this has already begun to occur, is develop treatments and vaccinations that will protect more people proactively ahead of time, so they don't have to catch the disease and can go about their lives without having to worry about that. Those treatments and vaccinations are going to be, it's going to take at least a year, by best estimates, 12 to 18 months to try to get those in place where we know they're effective and safe. So researchers are working on that right now. What we do have, though, already are tests. And so we can test for this virus. We can determine if someone is infected with the virus or not. The tests are not available in a sufficient amount at this point in this country. But testing can be a really important approach to stop the spread of the disease. If you have widespread testing and you know everyone's status, and this is something that they've done effectively in South Korea, for example, you can use some of the other public health approaches to trace contacts and quarantine people who have been exposed, and then you don't need to do the mass social isolation, self-separation lockdowns that we're having right now, because you can target your restrictions more effectively if you actually know who's infected with the disease. Now, I'm going to turn to non-medical countermeasures. There are a number of ways that the law can be used to try to limit the spread of a disease. And I'm going to go through a couple of examples here. I'm going to start with contact tracing. So contact tracing was what I was just mentioning a minute ago. So if we know who's infected with the disease, and we know who they've come into contact with, and we can use, there's legal authority for public health officials to engage in contact tracing, interviewing the people who are infected, figuring out everyone who they might have come into contact with, tracking those people down, and then potentially using that information to ask all of those people to separate themselves from others for a period of time until they know that they're not going to keep spreading the infection, until they know that they themselves are not infected. And so that brings us to quarantine and isolation. A lot of times you hear these words used interchangeably, but they are not the same thing. Quarantine is restricting a movement of someone who has been exposed or potentially exposed to an infectious disease during the time that they could communicate that disease, be communicable to other people. And so preventing transmission by keeping someone away from others. This is different from isolation, which involves separation of people who are actually infected. And so if you have a positive test for COVID-19, or you're very likely to have it because you have many of the symptoms, the appropriate legal restriction would be isolation to keep you from other interacting with other people for the period that you might transmit the disease. Quarantine can apply to lots of people who don't have the disease, but may, and so you're being extra cautious to make sure the disease doesn't spread. Now, people who are under quarantine orders and who are under isolation orders should not be kept in the same place, because obviously many of the quarantine people will not develop the disease. They're not currently infected. And this was one of the big mistakes that was made early on with some of those cruise ships, where people were kept in the same setting, even though some were known to be infected and others were just thought to have been exposed. And so that has ethical problems if you have quarantined and isolated people together. Another area that I wanted to focus on really briefly is when you talk about quarantine powers. Quarantine powers can be exerted in a number of different ways. Most of the time, we're talking about a home quarantine, which means that you're just staying in your home, you're staying in the place where you live, and you're not interacting with other people. That we can contrast that with a work quarantine, where this has been implemented under certain kinds of situations in the past, where people who work particularly in high-risk jobs, perhaps healthcare workers and maybe others who are interacting with a lot of people, maybe people who are working in grocery stores right now, might be subject to a work quarantine where you can go home and go to work, but you shouldn't be going other places because you're at high risk for being infected. Traveler's quarantine applies to people who are entering from another place. The federal government has authority to quarantine people who come in from other countries believed to have a high rate of exposure. We're starting to see attempts to use traveler's quarantine by state governors to try to limit travel between states, and that has some other potential constitutional problems that I can talk about later, and maybe in the question and answer session. But generally speaking, states have pretty broad powers to quarantine entrance into their state for a reasonable period of time if it's scientifically supported by the evidence of risk that person poses based on where they're coming from. And then the last two categories here, institutional quarantine. This is taking people who are under a quarantine order or potentially an isolation order, putting them into an institutional setting so they don't stay at home. The advantage of this is you can treat lots of people or monitor lots of people at the same time. The problem with this, and this picture I think is a good example of why this could be problematic, right? If some of these people are infected and others are not, pretty soon everyone's going to be infected if you don't have sufficient space between them. Right now, there are some efforts to ramp up treatment capacity and areas where people can be treated using convention centers and other kinds of public buildings to help with hospital capacity. I think most of those plans involve putting people there who are not infected with COVID-19, but who have other medical needs that are not necessarily infectious disease and could be treated at that remote site in a way that won't expose others to risk. But that's an important consideration to keep in mind. There's also Cordon Sanitaire, which is it's essentially taking an area and drawing a boundary around that area and saying that people can't come in or out of that boundary. This beautiful picture I have here is actually a picture of Molokai on the island of one of the islands in Hawaii, which has been home for many years to a community of people who are infected with leprosy, and that was a version of Cordon Sanitaire. People couldn't come in or out of that community for fear of being infected. Now there are some better treatments for that condition, and so it's not as necessary anymore. But there are some problems with the idea of Cordon Sanitaire. It's a fairly blunt instrument. It can also create incentives for people to try to flee. So if you think you're going to be put under a lockdown order, and this can happen with some of the social separation orders that are going on right now too. If people think they're going to be locked down in a way that really restricts their movement, there can be an incentive to try to get out of that lockdown area, and can end up spreading the disease more than stopping the spread of the disease. I also want to talk about really briefly, because I know I don't have too much more time. I want to talk about community containment strategies. All of the powers I was just talking about, quarantine and isolation powers and Cordon Sanitaire orders, those are mandatory dictates from the government using the police power of the in most cases the state government, or sometimes by extension local legal authority can be used that's delegated from the state. But all of that being said, a lot of the community containment strategies that are available don't require mandatory orders. And so you can have a lot of the social separation provisions that are in place are not necessarily being imposed in a mandatory way, or they're being imposed with large exceptions. And so a lot of the state social separation orders that are in place right now are framed in a way that keeps people at home unless you absolutely need to be traveling around. But the list of exceptions that allow for travel, obviously seeking healthcare is one of them, getting food and medicine is another. If you're in any kind of essential industry, you're allowed to keep working. Where that dividing line is not always completely clear. But what we see is that these strategies will work if people actually comply with them. They don't necessarily need to be attached to a legal sanction. So in other words, a penalty, arrest or fine if you violate those orders. Now, we've seen states and local governments increasingly move to the more restrictive orders that actually do allow for the imposition of arrest or a fine. Actually enforcing that is going to be pretty much impossible in a large scale way. And so one of the concerns that's often raised in this context is widespread mass quarantines or widespread use of legal powers to try to suppress movement of the population ends up being unenforceable. It ends up eroding trust. And it also, to the extent that it is enforced, often it is enforced in a discriminatory way. And so that can be problematic. And so the last, and I should also mention, you've all seen this graph. This is why we're doing social separation. We're trying to flatten the curve. We're trying to make sure that the rate of infection is less rapid, and that the peak of the outbreak doesn't all happen at the same time. We want to spread out the length of time in which people get infected so that our healthcare system can adapt and can handle the capacity, the surge of cases that it's going to see. The other thing that we're trying to do right now is to raise that bar. So that dotted line, the healthcare system capacity, by producing more materials, more supplies, changing factory production from other types of things to needed medical supplies like ventilators or masks and other personal protective equipment. And if we succeed in doing that, we can greatly reduce the number of deaths that occur from this outbreak. By the way, among the powers that governments have, the federal government has the Defense Production Act, which can be used to compel manufacturers to make needed supplies, and state governors also have similar powers to commandeer facilities for needed to make needed resources. The final thing I'll mention is travel and border controls. And obviously, the federal government has broad power to limit travel at international entry points. And this approach might be effective before the introduction of the disease into the country. But we know at this point that at least in the United States, this disease is extremely widespread. Obviously, some areas are affected more than others, but we really don't know with accurate data how widespread this disease is because we haven't been doing enough testing. And so policies and proposals that seek to limit travel right now need to be scrutinized from the perspective of, is it necessary to stop the spread of the disease? Or is this just being put into place as kind of a reactionary approach to try to blame somebody else and pretend that that keeping people out is going to stop the spread? Right now, the spread is happening here. We need to be acting rapidly here to do all sorts of things to stop the disease from spreading. And that's where a lot of our focus should be. The final, another thing about implementing sudden border restrictions, this is what happened a couple of weeks ago when the president announced that there were going to be restrictions on travel to Europe. Within the next 2 or 3 days, thousands and thousands of people immediately flew back to the United States so they wouldn't get stranded. And that led to huge crowds at airports, which is a great way to spread disease. And so thinking through the effects of policies and how they're going to influence people's behavior is really important. The last thing I'll mention is, we're facing down an impending crisis with our scarce medical resources. And we know that if these resources become scarce, and they're likely to in the next couple of weeks, it might pose some really difficult decisions on the part of our healthcare workers and how to allocate these scarce resources. There are a lot of plans and ethical guidelines out there that exist to try to help healthcare workers make these decisions in an ethical way, but it's the greatest challenge that many of these healthcare professionals will ever face, because it goes against their normal approach. You treat everyone who shows up to the maximum ability that you can, and that's not always going to be possible if there isn't enough actual equipment or supplies to treat everyone. And so this is going to give rise to a lot, in addition to the ethical dilemmas that are going to happen and the harm that's going to occur because we don't have enough and haven't planned adequately to have those resources in place. We're also going to see legal challenges and lots of litigation around this, both prospectively to try to influence how allocation is done on the front end, and also retrospectively, I think there are going to be lawsuits about standard of care and how that's applied in this situation. So I'm going to stop there because that is probably about the amount of time that I have. I want to make sure that Dean Seeger has some time to talk about his topics, and then we have some time for questions. So thank you.
Hello, I hope you can hear me. I appreciate Lance's presentation very much, and let me get to the top of my slides here. And I want to mention that Lance and I have worked together on a couple of projects in the past, so it's really delightful that he invited me to participate in this project. Lance and I worked together to revise the Crisis and Emergency Risk Communication Guidelines for the Centers for Disease Control, which are really robust materials. I'll talk about them a little. Unfortunately, our administration has not been following those guidelines very successfully, which has contributed to some of the difficulties around this. Lance and I have also participated in some projects around the Flint water crisis, which is a similar kind of issue in many ways. So I've been doing crisis and emergency risk communication work for over 35 years. I have a lot of stories about a lot of bad things. I'll try not to go through all those stories. Just as the law is critically important in managing these kinds of infectious disease outbreaks, so too is communication. Communication is one of the fundamental tools we have for risk and crisis management. So I'll walk through just some real highlight issues about communication under a crisis situation and some of the challenges that we face in a circumstance like this. So just for a little context, let me talk a little bit about what crisis is. Crisis is generally recognized as an event or a series of events that has three defining characteristics. First of all, it is somehow surprising. It is unanticipated. It creates a high level of uncertainty or a lack of adequate information, and it's outside our normal comfort zone. Now, anyone in public health will tell you that a pandemic like this was not surprising. We've seen this before. It's been modeled. It's been planned for. But for decision makers, politicians, and many in the public, this is a very surprising event. We know that almost every crisis we look at, there are warning signs, there are risk signals, but in general, those signals go unrecognized or unattended to, and that's what allows a crisis to emerge. Second characteristic is a perceived threat, high priority goal, which is threatened. In this case, this is a very, very threatening disease outbreak. We not only have mortality and morbidity, but we have significant economic losses. And then short response time. Anytime we have a slowed response in a crisis condition, our harm is increased. And certainly we've seen that in this case. Lance mentioned some events, some recent events. SARS, 700 deaths, MERS, Middle Eastern Respiratory Syndrome, 400 deaths. Those were both coronaviruses. Ebola was really not a significant risk in this country, although there was great public concern. Seasonal influenza, typically we have somewhere between 30 and 50,000 deaths. 2018 was a bad year with 80,000 deaths. COVID-19 is optimistically predicted to create 250,000 deaths in this country. That's a very optimistic projection, but I think we will probably see that number of deaths. I'm going to talk a little bit about the perception of risks and perception of COVID-19. COVID-19 has all the features that suggest that the public is really going to be very concerned about this, as we obviously have seen. It's very threatening to our personal health, the health of our family, the well-being of our communities and our economy. It's a novel virus. As Lance mentioned, there is no natural immunity to this virus because this is the first time we've really seen it in humans. It's unfair. It's treating people differently, and there's no really rhyme or reason that we've been able to identify in terms of why some people are affected so much more directly and strongly than others. It has relatively exotic origins. You know, we don't know exactly where it came, which animal vector it came from. Some people are saying bats. Some of the evidence is pointing to bats, but it's an exotic origin. It's involuntary, unlike smoking or drinking and driving. It's something that we don't bring on ourselves. And the uncertainty is quite high around this event. So these are features that really suggest the public is going to perceive this as a very risky disease. This is a definition of crisis communication, just to orient ourselves. Crisis communication is a process of planning, developing, and disseminating both informational and persuasive messages for avoiding, containing, and managing harm. And those messages are really important because they help give the public information about what to do and also try to convince the public to take particular. I'll talk about that just a little bit more in just a moment. So some of the conditions of crisis that are important to consider from a communication perspective. First of all, there's a phenomenon known as the social amplification of risk. And this is where a risk factor becomes manifest in social media or other media forms and becomes amplified beyond the actual risk factor. Obviously, we're not seeing that so much here because the risk factor is so high. There's also a couple of interesting myths that we should just mention. The myth of panic and the myth of looting. In general, people respond, the public responds in a pretty rational and logical way during a crisis. Early on in this event, many people were out stocking up on chocolate chip cookies and toilet paper and other important resources. And they were often accused of panicking, but now that seems like a really logical kind of response. So I don't really see any behaviors that I would characterize as widespread panic. In this case, I think most of the responses have been pretty logical and pretty rational, except maybe for some of the responses of our politicians. There's also a myth of looting, the idea that somehow crime is going to shoot up and there's going to be widespread looting in the streets around an event. I saw a report yesterday that the crime rate in Detroit is down 40%, and most of our criminals are self-quarantining, or maybe they're helping their neighbors. Those are the kinds of conditions we typically see in a crisis. We also see cascading events. We see closures. All sorts of businesses are closed now. We see shortages of key resources. Supply chains are very badly disrupted around this particular event. We see secondary disruptions to the economy, and we also see social stigmatization. Early on, this event was associated with particular ethnic groups. In fact, some of our politicians referred to this as the China virus, and that really stigmatizes particular groups around this disease. This is a model that was developed for the Centers for Disease Control, their crisis and emergency risk communication model. I won't go through this in great detail, but just to show you that a crisis evolves through a series of stages or phases, from a pre-crisis stage to an initial event, through a maintenance stage into resolution, and then finally to evaluation stage. And that our communication behaviors and strategies will vary depending on the particular stage of the crisis we're in. So I want to go through these very quickly because we don't have a lot of time, but these are some of the things that we should be doing in a crisis situation. Acknowledge the uncertainty, address the rumors, acknowledge the high perceived threat, be consistent and credible, promote self-efficacy and actionable messages, be simple and understandable, and be timely and tailored. So I'll talk about each of these just real quickly. High uncertainty, a crisis it's an important issue, and there's inadequate information about that issue. So it's a condition that we sometimes refer to as the information deficit or the information vacuum. So we want information about the nature of the risk, the causes, the actions, the consequences, short-term, long-term. I'm getting dozens of questions from people now about how long is this going to last? How long do I have to stay in my home? And so there's a lot of questioning and a lot of need for information, and we don't necessarily have all those answers. Rumors and rumor management. Rumors are propositions or hypotheses that develop in the absence of verified information. And we see so many rumors going around right now. Rumors about how to treat this disease, what you can do to avoid it. There are rumors about people being arrested for breaking the governor's order. So there are a lot of rumors out there, and those rumors are really partly a function of this information deficit or this information vacuum. So the more we can provide, verified information in a crisis situation, the more we can tamp down those rumors and probably avoid behaviors which may be less productive or less helpful. One of my favorite rumors is that by eating cow manure, you can treat yourself for COVID-19 and you'll be immune. So I don't recommend that, but that's one of the rumors that's out there. High perceived threat, we talked about. These threats, really are very personal in many ways. My family is at risk, my children are at risk, my grandchildren are at risk, my community is at risk, my students are at risk. So it's a very personalized experience with this particular disease. I'm at risk. I was delighted to know that I now fit into one of those high risk categories because I am now officially over 60. That was an interesting insight from this particular disaster that I'm now high risk. Messages should be consistent and credible. Credibility is really a function of two factors, trustworthiness and expertise. So trustworthiness has to do whether or not we believe the source is really being honest and open and really has our best interest at heart. Expertise has to do with our subject matter, credibility, and the degree to which the messages are grounded in legitimate real science. So we look to credible sources in a situation like this. Subject matter experts, the best example is Dr. Fauci, are credible sources. There are also social agents, people in our communities that we deal with regularly and we interact with regularly. Those typically are also seen as credible sources. And then sometimes our friends and family, we will look to them to provide consensual validation of messages. So I want to know what others are doing, how others are, getting food, how others are social distancing or doing isolation. And that provides consensual validation that my behaviors are consistent with what other people are doing. And then consistency of messages across sources. It's really very problematic when we have sources which are contradicting one another. We've seen this a lot in the national dialogue, where we have the president being contradicted by Fauci and Fauci being contradicted by the president. It's really created a very high level of confusion and increased the level of uncertainty in this circumstance, where we really should be moving to reduce the level of uncertainty. Self and community efficacy have to do with giving people actionable, meaningful things to do that can reduce the level of risk that they face. So we've all heard, wash your hands, cover your cough, stay home if you are sick. I will just emphasize that again, because that's created a lot of problems at many organizations, staying home if you're sick. And stay informed from credible sources. Don't turn necessarily to Facebook as your source of information for how to manage this event. And then social distancing is huge, as Lance indicated. This is the primary mechanism that we're using to convince people to manage this event. And we need to persuade people and convince them to stay home. And that's a really, really difficult problem. We're having some success. We will also have another really interesting problem down the road when we have to convince people that now it's safe to actually go to work or go to school. Messages should be simple and understandable in crisis situations. Our capacity to process information is reduced, so we should avoid technical language. We use posters and reminders to, sort of reify the message, and we need to be redundant and frequent. So if you've been on campus, you've seen a lot of messages in restrooms, for example, about reminding you to wash your hands. If you have been in the airport recently, you see a lot of notices about various travel restrictions and other things to sort of remind us of the things that we should be doing and aware of. Timely and tailored. I talked a little bit earlier about how important it is to be rapid in responses to a crisis to sort of limit the harm. So we need to be very time sensitive in our message. We need to update messages frequently, and we need to recognize that there are multiple audiences. And often those multiple audiences are audiences who don't always share our language or our culture. So we also need to be sensitive to those issues. So what can we do? Well, we need to plan and anticipate. We need to assess our policies and institutional policies as well as governmental policies. We need to communicate, stay informed, identify partnerships. And my argument is that we need to get into the room. We need to be part of the conversation around these events. There's a lot of a need for people to engage and be part of the conversation. And I think that's really important at all levels right now. So some of the challenges, we've had a very disorganized, decentralized response at the national level. Many of our governors have stepped up and provided sort of an emergent kind of response, which has been very effective, but it really hasn't entirely countered this very ineffective national level response. We need to recognize that this is a long-term event. We'll probably be in some form of social distancing for well into the summer, certainly into June. This is not going to end quickly. The scope and scale of this event is really quite large. I mean, we haven't seen anything like this in this country since 1918 and the pandemic, the Spanish flu pandemic. Returning to normal, whatever normal is going to be very difficult. It's very hard once you convince people not to do something because it's risky, then to convince them that now it's okay to do that thing. So it's going to be a difficult transition to bring people back to work and back to school because they're still going to feel threatened based on previous messages. And then we need to learn the lessons. And you know, one of the things that I've argued in my own research is that there are important lessons embedded in a crisis, but we often learn the wrong lessons. So we really need to think about what comes next, how we can learn lessons, and how we can really accommodate a new understanding of risks based on this event. So I mentioned the crisis and emergency risk communication materials that Lance and I both worked on. This is a link to those materials. I really strongly encourage you to take a look at them. Lance's chapter is the best, by the way. And this is a link to the work we did with the World Health Organization, part of what we did with them in terms of their response capabilities. Here are some references if you are particularly bored and can't sleep that I can recommend. And I'd be happy to answer any questions or participate in any a dialogue that we can have now. Thank you.
Wonderful. Thank you so much, Professor Gable and Dean Seeger. That was excellent information, and it has generated quite a few questions. So I'm going to just start as they came in and let you both continue to enlighten this wonderful crowd we have today. The first question, I think probably this is posed more toward maybe Professor Gable. If a vaccination is created, is it likely that this would be mandatory? Given the severity of this illness, would this be treated differently than other vaccinations?
Well, I think my best guess on that is that it would not be treated differently than other vaccinations. I think, honestly, as this vaccination becomes available, which hopefully it will be, and you know, and we're presuming that we can create a vaccination that is sufficiently effective and safe against this disease. You know, assuming that that can be done, and assuming that it is done in a fairly rapid time frame, meaning like within the next year and a half, I think initially we're going to have the opposite problem, which is there probably won't be enough production of it, or just the logistics of getting it to people is going to take a while, and I think more people are going to want the vaccination than can get it right away. That being said, you know, once the vaccine is available, I don't foresee this becoming any kind of mandatory requirement that all citizens have this vaccination. What may happen, though, is that if people refuse the vaccination or don't have it, they might be subjected to additional restrictions. And so they could more susceptible to be putting under a stay-at-home order, a quarantine order, if they refuse and they're at risk of spreading the disease. Obviously, the ultimate goal is to have a level of vaccination in the community that is high enough to create herd immunity so that the disease cannot spread within the community because there aren't enough susceptible people to it.
Great. Thank you. Thank you, Lance. The next question here, are state and local powers to respond to the virus limited by the federal constitutional right to interstate travel?
So well, it depends on which powers we're talking about here. So clearly the state or the federal right to interstate travel would prevent states from imposing an all-out ban on citizens from other states traveling into their states. And so if, I know this was proposed in a couple of places, or at least it's been discussed that certain states would say, you know, we're just not, you know, Rhode Island is not going to allow anyone from New York to drive into Rhode Island, and they're going to pull every car over who comes into the state and force those people to go back to New York. That would not be constitutional. At least it wouldn't be consistent with the fundamental right to travel, interstate travel. What states could do, though, I think constitutionally, although this remains to be challenged, and it's not 100% clear how it would come out. If states actually want to implement quarantine orders from travelers from other specific states, they're on a firmer constitutional footing there, because the state powers to quarantine, as long as the use of those powers are narrowly tailored to meet a compelling state interest. In this case, I think those criteria could be met, at least arguably, by the risk being posed by travelers from places where there is already a really high rate of infection. So I know Texas was talking about putting people traveling from New York under a 14-day quarantine when they arrived in Texas. I think that is on firmer constitutional footing. But again, because this is such an unprecedented situation, it's hard to say for sure how a court would evaluate that. But I think that's more likely to be upheld as constitutional.
Right. Thank you. And I think this next question sort of follows up that a little bit. You had mentioned that Cordon Sanitaire order, and somebody just wondered, does that raise issues of restraining movement?
Well, sure, and in fact, all of these restrictive powers, whether it's Cordon Sanitaire or quarantine or isolation orders or travel restrictions, they all implicate freedom of movement. Obviously, there are fundamental rights to travel, but there's also just rights to assemble and rights to move freely. But those rights are obviously limited by other considerations. If the government interest is sufficiently strong, those rights can be restricted, at least for a period of time, while there's a great deal of risk. Now, I will say that I think Cordon Sanitaire is more susceptible to constitutional challenge than some of the other powers, because it's done in a very blunt way, and it's just saying, well, you can't enter or exit this particular area regardless of who you are. It's even more constitutionally suspect if it's done in a discriminatory way. So that there was a case, it's more than 100 years old now, it occurred in San Francisco around the turn of the 20th century, and there was a plague outbreak in San Francisco, and the city imposed a quarantine. It essentially imposed a cordon sanitaire on the neighborhood where all of the Chinese Americans and Chinese immigrants lived in San Francisco, but only to that neighborhood. And that was actually found unconstitutional by the California Supreme Court, finding that the restrictions were imposed with a discriminatory animus against people of Chinese descent, and therefore were unconstitutional. That could happen here as well. And we haven't seen those kinds of orders targeted toward a particular subgroup. But I think that anything like that would be on very shaky constitutional grounding, because of it wouldn't be supported by the underlying science that would be targeted in a discriminatory way towards someone's national origin or other characteristic that might be a protected class.
Thank you, Lance. Yesterday, the White House was estimating between 100,000 to 200,000 deaths in the U.S. if we do everything right. Today, the figure is raised a little bit more to 240,000. Is the change based on new information, or is this an example of what happens when you put a frog in a pot of cold water and slowly turn up the heat?
I guess I can take that particular question. Although I don't put a lot of frogs in water and turn up the heat, I can say that there's a natural tendency among elected leaders and leaders in general to over-reassure and discount the risk that actually exists around an event such as this. And this is generally recognized as a very significant problem in crisis and emergency risk communication, because it undermines the credibility of the speaker, and it creates distrust in additional information that may be provided. So I think our current administration has been really fallen into this trap, and I've written about this in a couple other places, of this over-reassuring. And it's a natural tendency. It certainly is understandable that elected officials don't want to create undue concern. Often this tendency to over-reassure is grounded in the myth of panic. And you've heard this a lot among our elected officials. They'll say, don't panic, everything is going to be just fine, we don't want people to panic. Well, people aren't panicking, as I said, that's a myth. But this myth of panic is used to justify this over-reassurance, and even worse, in some cases, justify withholding information from the public. So it's very unfortunate that our elected leaders often aren't grounded in some of these principles of how people behave in crisis and disaster situations. And that's tendency, that fact leads to this tendency, I think, to over-reassure in many cases.
Thank you, Dean Seeger, because in a follow-up to that, and I think that's why everybody's so excited to have this opportunity to try to get as much credible information as they possibly can. One of our participants said that you had mentioned that about 240,000 deaths was an optimistic estimate, and he's just wondering if he heard that correctly, and if so, What's the estimated time to reach such an apex of this epidemic?
You know, I don't know that I don't know that I can answer that question in terms of when we will get to that number. I think that many public health officials and epidemiologists, as they began to see the rate of infection emerge in this country, were upping their estimates quite rapidly in terms of this. I think I've heard estimates now of 250,000 is sort of the optimistic number, and going much higher than that. I won't give you the pessimistic number, but it's a pretty pessimistic number. And you know, the curve here, the infection curve is going to determine when we reach those kinds of numbers. I know that the infection rate in the city of Detroit and Wayne County is doubling every 2 to 3 days. And we can expect that to continue for some time. In general, there is an expectation that it will probably be well into May before we see, you know, some stability and some leveling off of this particular pandemic for our communities. Maybe Lance, you have some additional information or thoughts about that.
Well, all I would add is that I think, you know, the projections that I've seen, and, you know, listening to people who are experts in epidemiological modeling and know how these infectious disease rates and are likely to grow over time, you know, tend to be on they tend to raise those more pessimistic projections, especially because we had a relatively slow response. You know, in places where there were really rapid efforts to have widespread social separation, even though that takes a while to show its results. So it will be 2 or 3 weeks post strong social separation efforts before we start to see that infection rate slowing. It won't stop, but it will slow. We've seen that working now, you know, in Italy, where the outbreak was extremely bad, and it still is extremely bad. They initially allowed a lot of the spread to happen and didn't impose any kind of restrictions. But then they put in some very significant restrictions. It took about 2.5 weeks, but now we're starting to see their numbers level off. And we're likely to see that here too, if we actually have consistent application of these approaches. The problem right now is that in the United States, there are some communities that are doing very stringent social separation approaches, and then there are others who are either doing it hardly at all or inconsistently. There are still many states that have not done statewide social separation orders, and those states in 3 to 4 weeks from now are going to be looking really badly hit with these infection rates, because they're allowing the spread to continue unchecked. Right now, we don't have a better method to stop the spread than staying apart, and in the long term that will change. But that's right now, that's the best thing we can be doing. And so, you know, I unfortunately think that those projections of 240,000 are low. But you know, I don't have any basis to know what the actual number will be or when it will come. But the next couple of months are going to be really bad.
Just a related follow-up to that is, you know, it's important to recognize that denser communities and places where people are in lower socioeconomic positions really creates higher infection rates and higher mortality rates. And this is a phenomenon that is manifest throughout the crisis literature, that poor people who live in more difficult conditions are generally much more vulnerable in these circumstances. One reason we see Detroit as such a significant hotspot right now is for that very reason. Detroit continues to be a significantly economically disadvantaged community. And many people in Detroit simply they don't have the opportunity to separate and do social distancing in the way that others may have. They can't go out and buy, you know, a month's worth of food because they don't have the income to buy a month's worth of food. They may need to go check on sick relatives. So our community is really disadvantaged, as are many others, in managing this particular event.
Yeah, and I'll add one more thing to that last point, which is one of the things that we can be doing right now and should be doing right now to try to mitigate the extent of the harm, in addition to trying to take every step we can to expand the capacity of our healthcare system to treat people who are affected. We should be doing everything we can, and this is within the power of governments to really influence, is to expand our social support within our communities, within our society, to allow people to stay home. And so if someone is worried that they're not going to be able to pay their rent and they're going to be evicted next week, or evicted today when they don't pay their rent on April 1st because they don't have income right now, they're going to be much more inclined to go out and try to keep working. And if people are feeling like the only way to make ends meet is to continue to interact with others, and the only way to keep their family afloat is to try to keep bringing income in, then that's going to be a strong incentive not to stay at home. The more we can do right now to provide financial support for people, probably direct financial support is the best approach. And I know Congress has started to do that, although the $1,200 is not going to be nearly enough. But then also protections like having moratoria on evictions and on utility shutoffs, other kinds of, expanding access to Medicaid, expanding access to unemployment insurance, and other kinds of social support. Those are the kinds of things that can really not only help people make it through this period of time economically, but also can help them actually be able to stay at home and stop the spread of the disease. So it works in both ways. And so those are really important initiatives to be pushing forward right now.
Definitely. Thank you for pointing that out. And I think some of our town halls down the road will probably start to address what some of those measures are. One question, and I see that we still have several participants in the room, which is great. We still have a few more questions to go through. So if you gentlemen still have some time, I'd like to be able to continue. Are there any protocols in place on how to remove the shutdown measures? Is a second wave likely once the social distancing recommendations are lifted?
So let me talk a little bit about the challenges of moving away from the shutdown notice, the shelter-in-place notice. I don't think we have a lot of information about how that will happen. We do know that, again, as I said, when we convince people that things are unsafe, that it takes a significant amount of time to then convince them that they are safe. There are still people in Flint who are drinking bottled water, at this point, even though the water test is very, very safe and very secure. So my expectation is that we will probably roll out a process whereby we slowly release the social distancing provisions. Some of those may initially involve regular temperature checks, continued social distancing on work. But this is a real significant challenge. And, there's a lot of pressure now already. We've heard it from our president. We've heard it from others to get us back to work. Public health officials are very concerned about that. But we probably will be looking at a process where we take small steps, assess the impact of those steps, and then begin to move forward from there.
Great.
Yeah, one strategy that has been proposed that I think makes some practical sense, although it requires quite a ramping up of capability that we don't really have right now, is to follow an approach similar to what they did in South Korea, where they did extensive testing of as many people in their population as possible. So if we can have widespread testing, and that allows us to determine in great detail, person to person, who is infected with this disease, who they've come into contact with, and then also who has already had the disease and has recovered. So that would be a different test. It would be a serological test to determine if your body has fought off the disease successfully. We can target the restrictions much more closely to who's actually a risk of exposing other people. And that will allow for a greater number of people to be out and also to feel confident about interacting with others if they know that they have a clean COVID test, or even better, if they've recovered and they have some level of immunity and can't be reinfected for a period of time. That will allow us to loosen those restrictions. Now, actually implementing that and managing the logistics of how that would be done is incredibly complicated. But that's another possible way out of this situation, to move from an overall policy where everyone is socially distancing to a policy where people are it's being done in a more targeted way, and it could be periodic. So if you have a clean test, but then you're exposed, you might have to go back into self-isolation for a period of time, and that might happen on and off for the next year, intermittently with different groups of people, until we really have a place where we can have a vaccine or some other intervention, or a sufficient level of immunity in the population where the risk is much lower.
Thank you, Professor Gable. As a follow-up to that, one of the participants is wondering, do the states have a legal duty to increase testing efforts, or at least make reasonable testing efforts, that is like using private labs?
Well, I would say that the states have an ethical duty to do everything they can to scale up testing, and also to scale up production of other needed supplies. Whether that would translate into a legal duty that could be enforceable is a harder, that's a harder question, and one that I don't think there's a clear recognized responsibility in that specific, to follow that specific approach. I do think, though, that we are going to see litigation based on the fact that both state and federal governments, and also just lots and lots of institutions were so inadequately prepared for this situation, and I can't predict how those will come out, but I think we're going to see, after this time of crisis passes, and we're looking back not only on lessons to learn for the next time, but also on trying to figure out what went wrong. I think we are going to see some of those kinds of discussions. I think it would be a creative approach to try to use a lawsuit to try to spur greater action, especially in states that are slow and moving. I'm not sure how courts would respond to that, but that's something that's actually, I think, worth considering.
Thank you. This one I'd like to direct toward Dean Seeger. This participant says, I observe a lot of differences in the way the US media reports on COVID-19 compared to my home country of Germany. How do the characteristics of the US media, that is that 24-hour news cycle, privatized media, shape crisis communication?
So there's a lot of effort right now to sort of do cross-cultural comparisons of some of the communications associated with this particular phenomenon. There is a tendency in US media to sensationalize these issues, and we also have a really interesting philosophical or political bifurcation of our media right now. We know that those who are consumers of particular kinds of media have a very, very different perception of the risk associated with this event than do others. So I do think the privatized media, the heavily politicized media in this country has really contributed quite significantly to the way the public is responding to this risk, understanding this risk, and the kinds of behaviors that they're taking. I mean, we've seen just some really outrageous behaviors recently of individuals, religious leaders, calling their congregations back together for services, thousands of people coming in for services. We've seen some particular educational institutions call students back for face-to-face classes right now. And those kinds of behaviors are just really fundamentally irresponsible, but I think are grounded in this radical political bifurcation of the media.
Interesting. Thank you. This isn't the first emergency or disaster in our lifetimes, although it's certainly the widest spread. Are there lessons to be learned from 9/11, Hurricane Katrina, et cetera, that might be applicable here? And I think either one of you could take that.
So there is a very robust body of research in disaster studies, crisis studies. It's very interdisciplinary. It has roots in political science, emergency medicine, sociology, and so there's a very significant body of knowledge about these particular events, and we are able to use some of that information to inform what's going on now. One of the challenges is that sometimes those lessons, as I've indicated, are hard to implement. They are hard to get the public to really think about in a post-crisis environment. But typically what we will see is we will see a new understanding of risk factors. We will see a new set of policies and procedures for risk mitigation, and just a fundamental rethinking of the role of social institutions and social structures in managing risks. Some of you probably remember, if you're old enough, the time when you didn't have to take off your shoes and your belt, and when you went through the airport screening, that there was not that level of risk mitigation. But since 9/11, our whole understanding of what is risky in terms of flying has radically changed. We will probably see similar changes here. I'm hoping we don't learn the wrong lessons of this particular event, such as closing down our borders and not letting others come in. But historically, we've had a hard time implementing the lessons of a disaster in an effective way. I don't know if Lance, if you have some other thoughts.
Yeah, so I agree with everything you just said. I think that one of the things that's been particularly frustrating, as someone who has worked on these kinds of issues for a while now, and has been involved with some of the planning for these types of events. One of the things that we often observe is that right after one of these major crises, there are a lot of efforts put into trying to learn lessons and implement plans for the next time so we don't make the same kinds of mistakes, improve our infrastructure, improve our readiness and our preparedness. But as time goes on, that as the event gets farther and farther away, we forget the importance of a lot of those things. And so, I know one example of this is that after some of the recent infectious disease outbreaks about 10 years ago with the H1N1 flu that turned out not to be a bad pandemic, but everyone was worried would be, a lot of states had put lots of plans into place to be prepared and have excess capacity. I know the state of California spent like $200 million to have this stockpile that would mirror the federal stockpile. But then a few years ago when they had a budget crunch, they didn't invest to sustain that, and they just essentially got rid of all of those extra supplies. And so one of the things that we can do better next time, I hope we'll do better next time, is all of the lessons we learned about how to be prepared for the next time this happens. We can't forget them in 5 years or in 10 years. We need to actually remember that this is an important set of precautions and plans that we need to continually renew and update. And so that I think is really imperative going forward in trying to make sure that we don't forget the lessons that we've learned.
So let me just provide one little anecdote about that, and then I apologize, I will have to get off to take another call here. I was on the university's planning committee for H1N1 response, and there were really robust plans that were mandated by the Centers for Disease Control and the Department of Education around H1N1. Wayne State University, I thought, was very aggressive in developing plans, and many of us worked diligently to put together a very robust H1N1 plan. It was about 100 pages. It had committee structures. It had contingencies. When this particular pandemic, when the COVID-19 pandemic hit, the university crisis team pulled out that plan. Fortunately, there were some of us who still had it. Pulled it out, read through it, and almost many of the provisions were still operative. And so we were able to move very quickly, I think, and I think Wayne State has been very successful in its effort to manage this event, in part because we had that existing structure, albeit 10 years old, which we were able to quickly adapt to this particular circumstance. So an example of how you can learn from these events and maybe in some ways you didn't expect. So I apologize, I have to get off for another call here, but I really appreciate the opportunity to speak with you today, and enjoyed this. And if there are other things that I can do, please feel free to contact me. Thank you.
Thank you so much, Dean Seeger and Dean Seeger. And I think that's such a nice way to end on such a hopeful and lovely message. And one of the things that our communications department wants you to know, that if you want to be directly emailed a copy of this recording and any of the supplemental materials, the slides, the links, etc., please email lawcommunications, that's all one word, lawcommunications wayne.edu. And definitely keep an eye on our Twitter account at Wayne Law. Thank you both again, Professor Gable and Dean Seeger. This has been exceptionally informative, very well done, very, very timely. We thank you so much for your time, and we hope to see many of you back next week. All stay safe. Thank you.